Welcome everyone to today's webinar. I'm Emily Rackley with Becker's Hospital Review. We will begin today's webinar with a presentation. We'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will send a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Oliva is Vice President and CMO at Nuance. Dr. Oliva draws on over 15 years of CMO experience. Previously serving as CMO for Borgus Health, he continues as a physician executive consultant. Dr. Oliva is board certified in family medicine and is a fellow of the American College of Physician Executives. He continues to practice clinically as faculty for a family medicine residency program. As CMO, he personally has been involved with the implementation and expansion of clinical documentation programs since 2004. Dr. Coleman is CMIO for evidence-based medicine, working on several projects to improve usability of EMRs for clinicians and provide EMR and clinician tools to address changes in payment and coding, including ICD-10. Prior to Nuance, Dr. Coleman was Medical Informatics Officer for Lifespan, a 4-hospital system in Providence, Rhode Island. During his tenure, 3 of the Lifespan hospitals achieved HIMSS Analytics Level 6 designation, and the system received full meaningful use funding in the first year of the program. Dr. Oliva, I'll now turn the floor over to you.
Great, Emily, thank you, and thank you everyone for allowing us an opportunity to chat with you today. Our real focus today is sort of two-part. One is to sort of level set again on the impact of clinical performance and value-based purchasing and how that connects to a revenue cycle and clinical outcomes. And then maybe talk a little bit about where's the future of clinical documentation improvement from the standpoint of where technology may have a major impact as we move forward in this world of value-based care, especially as we move to more payers being focused on that aspect. So that's really what we're going to chat about today, and certainly at the end of this, if you have any questions, we're more than happy to answer them. First thing that I want to show you is this. You're probably familiar with this, but the whole point here is that, and this is just a micro shot of the Medicare value-based purchasing program, but back in 2013, 2014, the majority of, or any single key performance value was in the process of care indicators, and pretty heavy on core measures and those types of things. And you can see that there has been a distinct movement away from process measures to performance and outcome measures over the years. So in essence, actually, all of the measures starting in 2018 will be outcome measures. Experience of care stays pretty high, but you can see that movement into the safety domain and continued outcomes of care. All of those now become outcome or value-based outcome measures. And then you have this piece of efficiency of care, and also this is a place where people forget that this is also an outcome measure in the sense that all of these measures, efficiency of care, outcomes of care, and safety domain, are all in some way severity adjusted. So not only is your performance in these areas vital in order to score well in the value-based purchasing program, it's also vital that you accurately portray the population of care you're taking care of and capture all the severity and risk associated with that population in order to be competitive in that world. So now 75% of what we do in a value-based world is going to be severity adjusted. That brings us to sort of this sort of crazy diagram, I think, if you certainly look at it. And what it really does is try to capture what we've sort of called the clinical revenue cycle. And if we look at sort of traditional clinical documentation improvement, you start here at the bottom in this clinical performance circle. And you go here go here clockwise to look at what we typically do with clinical documentation. So physician and patient interact, there's documentation, and then we look at that documentation from a CDI perspective. We send back clarifications to the physicians. The physicians update their clinical documentation, comes back up, and then it goes to coding where we get revenue capture because those go on to the bill and we get the appropriate DRG. And in a traditional way, that's where we've stopped as far as looking at what our clinical documentation improvement activities, no matter what they are impacting. The reality, though, in a value-based world is that this circle then continues on because all of those outcome measurements that we talked about in that first slide are generated from the billing data that comes from here. And that's pretty important because not only how you perform in that clinical aspect of care, but how sick your patients look compared to others is all captured in this bill and then in the UB04 bill and then moves forward in the Medicare world. Those outcome measurements we use in multiple ways. It's used for value-based purchasing, but our quality department uses those to determine whether or not we have opportunities to improve care. And then those flow back into trying to improve clinical performance, and then we go back to that physician-patient interaction. It's this part in the value-based world that becomes absolutely vital as it connects to this part. Are you capturing everything that defines that per patient, not just those things that will drive revenue? And that's important as you think about these worlds going forward. So just a level set, especially when I talk to physicians, I like to put something like this in front of them. And if you're clinical, this will make pretty good sense to you. If you're coding, this will also make really good sense to you. Here's a 79-year-old female patient who presents with a left lower lobe pneumonia. On presentation, the patient's found to have an elevated white count of 19,000 with a left shift, respiratory rate of 24, heart rate of 110, temp of 102.5 with a blood pressure of 90/40 and altered mental status, admitted to the ICU, vasopressors if needed, blood culture, improving on IV fluids and broad-spectrum antibiotics. And when I ask physicians whether or not that's a really good note, what I typically get is yes, absolutely. It talks about what's going on with the patient. It talks about all the things that they're worried about and all the things that they're going to treat. And there's really nothing left here clinically that I don't need to know to take care of that patient if I'm coming in to take care of them. Then I throw this documentation up and say, okay, well, what about this? 79-year-old female patient who presents with a left lower pneumonia, sepsis, and septic encephalopathy, transferred to ICU, improving with treatment. Okay, so that basically, in essence, summarizes what's up here, but in this case, you're not going to get a very well-coded, optimized opportunity in your billing data, whereas down here, you're going to get basically sepsis with an MCC. Up here, all you're going to get is left lower lobe pneumonia without an MCC. Why is that important? Because my answer to the physicians is not either of these is important. It's probably that both are important. And the capture of all of this documentation is vital in helping them understand that they only get credit if they say this, but they don't get credit if they say number one. That's a problem that they don't understand and takes a lot of education for them to sort of get because it doesn't make a lot of sense to them. So what we tell physicians clearly is the only way that you're adjudicated from anybody outside of your medical staff, other than what you typically do in peer review within your medical staff, is through billing data. And if you don't get that billing data right, you are personally at risk. And I haven't been able to say that until the last couple of years. As we've seen physician payments be connected to their performance, but also as we've seen transparency bubble down not just to the hospitals in things like health grades and the performance at that level, but physicians directly being placed, their outcomes being placed out on the web for people to see. I bring you to this because in my mind, when this scorecard went out there from ProPublica.com, it really was a game changer as we think about transparency as it relates to physician performance and how they connect to this whole world of capture of risk and severity and the meaning it is to their futures. ProPublica actually went out and looked at 5 years of MedPAR data, and they looked at these areas of performance. And when they did that, they also looked at every individual physician that did at least 25 procedures in each of these areas across the nation. And in the past, what we typically saw was this. We saw the hospital, and then you would have sort of an average performance rating. Here you see these little individual click marks here. Some are in the red, some are in the yellow, and one is in the green. These are individual providers. And maybe even in the past it sort of stopped there, but it hasn't. And we've actually moved forward to the point where individual physicians are now being scored based on what that billing data says about their performance from a capture of outcomes. That's pretty important because when you think about that, you run into an issue of what do we do with that information? I mean, it's out there for the public to see. It's out there for the public to utilize. It also raises some questions about what do I do from the standpoint of being a primary care physician who may refer physicians or refer patients to physicians who have a poor rating. Do I have a responsibility ethically to tell the patient that they should go to that website and look at that since I know it's there? Or do I have an ethical obligation to look deeper into this before I refer somebody? It's an interesting question that we didn't have to answer before, unfortunately. So it is something to think about. And not only that, what does the patient do with that information if they're presented with it and then they know they're going to have a procedure or have been referred to a physician? So I think it's important to understand that the world is changing. We're becoming more and more connected to our outcomes of care and how those are measured. One of the things that we want to do before we start talking about technology is help understand that if you implement technology to help you do this clinical documentation improvement, can you be comfortable that the technology is actually going to be appropriate and significant enough to actually move the bar in clinical performance? So what we decided to do about a year and a half ago is do a study with a company called CareChex to evaluate whether or not only were we moving the bar on on improving revenue capture, but were we moving the bar on quality outcome measurements as they compared to others? And we looked at specifically these indicators, but most specifically risk-adjusted mortality as we look at the capture of severity, because risk-adjusted mortality is actually the cleanest indicator to look at. There's not a capture problem with risk-adjusted mortality as we look at that in comparison to others, because you either are discharged from the hospital alive or not. So it doesn't carry the same potential variability in capture that whether or not you capture the appropriate complication, whether or not you captured the appropriate diagnosis to get into a inpatient quality indicator, which are your value-based purchasing indicators, or a patient safety indicator. So if we're going to look at severity, risk-adjusted mortality becomes the cleanest look for us. And when we did that, if you think about a normal bell-shaped curve of all the hospitals in the nation and how they perform in mortality performance compared to everybody else, you get a typical bell-shaped curve. And this would be a rendition of all the hospitals, all 5,000 that are in the CareChex database, and how they perform. And those that are performing better are in this top area, the 90th percentile. Those are the top 10% of all hospitals in the nation. This is the top quartile of all hospitals in the nation at the 75th percentile, and the top 50% being right in the middle of the bell-shaped curve. When we looked at our partner organizations to see if we were actually making a difference, and understand that all of these hospitals, if you look at them, about 90% at this time, 85 to 90%, have a CDI program of some kind. Only sometimes maybe some of the smallest don't. You understand that we're looking at how we compare to other people that have a CDI program, not those that don't. So as we superimpose our performance, you can see that there was a significant movement to the left of the bell-shaped curve with our partners in their performance. 93% actually being above the 50th percentile. When we look at that specifically for each ranking, you can see that actually 37%, not 10%, of our hospitals were in the top 10%. 70% were in the top quartile, and 93% in the top 50%. What was important, though, was could we show that we were maintaining that performance over time? Were the strategies and the work we were doing within the CDI program actually doing this not just in 1 year, but year over year? And you can see as we go back 5 years of performance, this is the end of the data that we have available to us. You can see that the performance was relatively consistent across the board as you move back year over year. When we look at each of the variables, you also see that, again, mortality as an average rating was much better in our partner hospitals than what you would consider the average of all hospitals in each of these categories. But you can also see that as you look at the other variables, complications, inpatient quality rating, patient safety rating, again, these are severity and risk-adjusted indicators. So they're not as strong correlation here because we have capture issues, but in each category we outperform. Over here in patient safety rating, it looks like our partners are not performing, patient satisfaction are not performing as well on patient satisfaction. But again, this isn't a risk-adjusted indicator or not a place where CDI would impact. One of the things that we were concerned about was whether or not we would see a bias in the information that are in the hospitals that we were measuring. And a bias meaning, what if all the hospitals coming in were already at the 75th percentile? If that were the case, then it wouldn't necessarily be appropriate or fair to compare. And you can see here that when you look at pre-implementation and mortality rating, the average performance was 54%. Inpatient mortality indicators was 48.3. So the average was pretty much right in the middle of the performance of all hospitals. But after 1 year, you can see significant changes after implementation of the CDI program, and this is the key. The expected mortality went up. Expected mortality is not the care you provide in the numerator observed over expected, it's the denominator. That's what you told the world your patients were looking like from a severity standpoint. And pre-implementation, they were saying that those patients were 1.7. After implementation, on average, it went to 2.10, implying that we were capturing better diagnostic information in the coded record to get a higher expected mortality, which will then perform better against peers. And if you look at each peer group as we break them out by size, you can see that in each category, the expected mortality in the partner hospitals is significantly higher than those in the overall database. That's important because it would be pretty unusual that every single hospital that's a partner on average has a higher severity than other like hospitals in the peer group unless something is different in which they're potentially capturing better data. So what I want to do now is after we've sort of set the stage, what I want to do is look at how technology using the information that's in that program from a CDI perspective can be translated to technology on the front end to help drive as much of this capture as far forward as possible in a CDI world. So I'll pass this on now to Dr. Coleman.
And hello, and thank you very much, Tony. And hopefully you will now be seeing my screen. I think I told it to show my screen. And can you confirm for me, Tony, that you're seeing my EMR?
I'm not seeing your EMR.
Okay, let me try this.
I'm seeing your GoToWebinar.
All right. Tell me if it changes.
There you go.
Okay. I'm very sorry about that. So hi, I'm Reed Coleman. I'm one of the Chief Medical Information Officers at Nuance. And as I said in the introduction, before I came to Nuance, I spent 11 years as the Medical Director for Information Systems at the Brown University Teaching System. And what I want to show you is the concept of basically artificial intelligence and how it can work to address the issues that Tony has been describing. There is no question that to get everything that you need in the value-based world starts with good documentation, and one of the most important aspects of that good documentation is to identify very specifically what is wrong with the patient, both in terms of diagnosis and in terms of specificity of the diagnosis. So what we have been working on is a couple of solutions to address these issues. And I'm showing you a note a little longer than what Tony showed. And again, by the standard of most clinicians, it's not a bad note. It's an elderly lady, resident of a nursing home. I will point out that at that nursing home, they let her smoke and drink alcohol, which is the nursing home that I want my kids to send me to. And she comes into the hospital from the nursing home having developed cough, sputum production, high fever, and by the time she arrives in the hospital, she is tachycardic, tachypneic, febrile, mildly hypotensive, and has a pneumonia. And so she is diagnosed as having a nursing home acquired pneumonia. And as Tony has pointed out, although this may be an adequate note from a clinician point of view, it is not going to help pick up all of the elements that you need for value-based care. So, and by the way, what I'm showing you is real technology. This is not slideware. It's working in real time, which of course assumes that it isn't going to crash on me. And so I'm crossing my fingers and I'm clicking the button. So what we have done is we have sent the entire note to the cloud And by the way, that in and of itself, capturing the active note and sending it, is not exactly a trivial solution. Send it to the cloud where it runs through natural language processing, which is a form of technology that looks through the document looking for concepts. And I have to emphasize, it's not looking for words. Word searching is something that anybody can do, but it is looking at combinations of words, their relationship to one another, their position in the note, and extracting concepts. And what this note has done is it has extracted two concepts that are missing from the note. One is the type of pneumonia. The patient has methicillin-resistant Staph aureus pneumonia, or at least the patient is being treated for that, as evidenced by the fact that the clinician started the patient on vancomycin. The patient has a healthcare facility-acquired pneumonia, has a history of MRSA, and has all of these other findings. And then what we do is we allow the clinician to agree with that assessment and provide text that can be added to the note. Second thing, and equally important, and think back to the demo that Tony showed about a good note, this patient is indeed tachycardic, tachypneic, febrile, has an infection, has a mildly low blood pressure. This patient has sepsis. It does not say so in the note, but we have identified that that is a diagnosis that is supported by evidence in the note, and ask the clinician to add that to the note. And the clinician can do it very simply. And if you look at the note, you will see that those diagnoses have been added, that the patient has now MRSA and sepsis. Okay? So that is one aspect of how technology can help. And that addresses the concept of diagnoses that you are not necessarily picking up. The second aspect is the question of specificity of diagnosis. Now, I will tell you as a clinician, I am quite used to having clinical documentation improvement specialists interrupt me on my way to the cafeteria, on my way to see a patient, on my way to the office, my way to many other places to ask me to come back and correct a note. They may send me a page, they may send me an email. In my EMR, they send me an in-mail asking me to go back, open that patient's note, and consider adding additional information. What we feel is a much more appropriate approach is to interrupt the clinician at the point of documentation. So here is another note, again, not a bad note, fairly young man, shows up with chest pain, nausea, diaphoresis, shortness of breath. EKG is showing what is clearly a myocardial infarction and heart failure by X-ray, and the patient's going to be admitted and treated. What this doesn't show, but what we can identify, and that got a little big, so let me shrink it down, is we can identify that none of the four diagnoses mentioned in this note have enough specificity for us to be able to assess severity of illness, risk of mortality, other aspects in terms of the performance of quality measures, and incidentally, better ICD-10 coding, better billing, and better reimbursement under HCCs for an ACO. And for me as a clinician, most important in terms of improving the quality of care, it improves the diagnostic specificity of the note so that my partner, when she rounds on this patient tomorrow morning, knows exactly what I think is wrong and how to deal with the patient best by improving the specificity. And it's very easy for them to do, and I will just do one, utilizing our voice control. Select diabetes mellitus. Diabetes mellitus type 2, controlled, no insulin, diabetic nephropathy. And so when I add all of that to a note, what I notice as a clinician is that the advice about how to improve the note goes away. So this is not word finding, but it is the actual use of cognitive technology to analyze the note for concepts, and to take those concepts and to run them through a rules engine. And just for those of you who are interested, the rules engine that we are using runs off of AHIMA guidelines for this particular tool to improve specificity. It is AHIMA guidelines, and we are asking the clinician to add information to the note to make those improvements. We're asking the clinician to do it at the point of documentation so that it is real time, it is while the clinician is thinking about the patient, it is while the clinician has the chart open to that patient, and it's while all the information is fresh and is readily applicable. So two different approaches, both using the same concept, reading the note, running it through a natural language processing engine, running the concepts extracted through a rules engine, and presenting the results of the rules analysis back to the clinician at the point of care. From our point of view, asking this information at the point of care gives the optimum improvement in clinical documentation. Now, I would not begin to suggest that this kind of tool can replace documentation improvement specialists. What we can do with this kind of tool is pick up the 70 or 80% of the most common things that need to be clarified in a note. There is still a lot of work for documentation improvement specialists, but now when this chart goes down the line and the data is abstracted, quality measures are abstracted, the patient is put in the appropriate buckets in terms of risk of mortality as well as severity of illness. Risk stratification takes place so that all of those factors that Tony talked about that are present in value-based purchasing are accurate. This is the way to do it. Right at the point of care, get as much of the information into the chart accurately and quickly as we can. So those are basically two approaches. One, and I'll just run through it one more time very quickly, this is specificity. This is taking a diagnosis that is present in the chart, chronic renal failure, and asking for it to be specified. The other was taking a look at diagnoses that were not present in the chart and asking that those diagnoses be added. And since I've already fixed this one, it isn't going to show up the second time. But that is the purpose of the two different forms of documentation improvement, better diagnoses and better specificity, so that your value-based parameters are the most accurate that they can be and can do the best for your patient care. So I will stop there and turn it over for Q&A.
Perfect. Thank you so much, Dr. Oliva and Dr. Coleman. That was a fantastic presentation. So we'll now begin today's question and answer session. As a reminder to our audience, you can submit any questions you may have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll try to get through as many questions as we have time for. So our first question comes from an audience member who's interested in understanding what type of risk adjustment methodology you were using in that last demonstration, Dr. Coleman.
Actually, it was mine. So the risk-adjusted, this is Tony, the risk-adjusted methodology that CareChex uses is a statistical regression methodology. In order to try to keep that sort of as simple as possible, it's a methodology that looks at basically trying to line up patients to patients that look as close to each other as possible to identify what rate that indicator or that independent variable is experiencing. They do not use, nor does CMS use, nor does Healthgrades or Truven or U.S. News World Report, any of them. They all use statistical regression methodology. None of them use APR technology or APR-DRG methodology to report out performance indicators, because APR-DRG technology or APR-DRGs are a payments-based system, and because there are only 4 levels of performance in APR, DRG in APR DRG, it's not clinically, it doesn't reach the same level of granularity that you get with statistical regression. So you can have somebody that reaches a level 4 in APR DRGs, and everybody at a level 4 is going to have the same mortality rate within that DRG. But when you look at the regression methodology, those patients that are a level 4 may have extremely variable mortality rates. So, for example, a sepsis with pneumonia in an APR DRG level 4 may be a 28% mortality rate. All patients at DRG level 4 for that diagnosis will be 28%. When you look at statistical regression methodology, those rates may range from 10% to 90%. So that's the difference, and that's how you're being measured. Statistical regression is the methodology that everybody has looked at across the board, no matter, at least from the value-based payment world within Medicare.
Perfect. Thank you for clarifying that, Tony.
This
so
is
for our
Rick
next
Coleman.
question.
Yeah, I'm going to jump
go for
in. There's a second question from the same person about documentation. These tools are perfectly capable of reading nursing documentation and making a clarification request to the physician. So if the nurse, and I agree, a nurse cannot say sepsis if it's not present, a nurse can document hypotension, tachycardia, tachypnea, fever, infection, and the tool will read all of the notes in the record and make a recommendation to the clinician. So who does the documentation is obviously important, but we can present to the clinician the prompt to fix it. And then there's a second set of questions that came from a good friend of mine, Dr. Hale, asking first if a video will be available. I will leave that to the Becker's people. If the video is not available, I will say to any of our audience members, but especially to Dr. Hale, we would be glad to provide a webinar for your staff showing this technology, or to come visit you personally. So, you know, I appreciate the question, and we will be glad to do whatever we can do. And the other question that came up is, do major vendors have this technology? And yeah, I'm being as careful as I can not to turn this into a commercial for my company, let alone somebody else. But two of the major EMR vendors have included this kind of technology in their tools. And I'll just give you their initials, Cerner and Epic 2016. And we are expecting other vendors to come along in the same way.
Perfect. Thank you, Dr. Coleman. Just to jump in on that, in about a week after the webinar, we will be sending a copy of the presentation to all the attendees.
Thank you.
So to jump back into our questions, our next question from the audience is, real-time speech recognition technology would help our physicians because currently we have a manual process. Clinical documentation specialists follow behind physicians, asking them to be more specific in their documentation. Where do you suggest we begin the process of evaluating where and how this technology fits into our documentation process?
Well, you know, I agree that real-time is your best bet. I would like to say, since I work for Nuance, that the ideal is to tie this into the use of voice recognition technology so that the doctor is speaking into one of our tools and creating the note, and we're analyzing the note as you go. I will say, in fairness, however, that these tools that I showed you work regardless of how the note was created. But I think that you're never going to replace all of clinical documentation with real-time at the point of care prompting, but the more that you can do at the point of care, the better you're going to be. And if doing it with voice recognition at the point of care helps the clinicians get it done, then we think that's the best approach.
Reed, I'm going to jump in just as an addition there. One of the challenges that I've been looking at this CDI world for over 12 years now, since 2004 when I implemented the first program back as a CMO. And the challenge is that physicians don't seem to be necessarily learning, right? So the retrospective clarifications, when we look at clarifications, the type of clarifications that go out today versus the ones that went out 12 years ago, the same ones are at the top of the list. And part of that, I think, is because it's retrospective, it doesn't allow that physician to correlate it to what they're thinking at that time. I have a high level of suspicion that as you move this forward to real time where the physician is making that change while they're already still in a record, that they will begin to enter that information without being prompted in the future because it's immediate feedback, not retrospective feedback. So that's actually a hope as we look forward to this technology. And again, there are a lot of aspects of what a CDI does, a CDI specialist does, and that the technology can't do, especially as we look at things like appropriate sequencing of diagnosis, appropriate principal diagnosis capture, those types of things to help the process of getting the appropriate DRG together. So all those things, I think, by moving things forward, not to mention that I do it once and it's done, and I don't have to worry about it again as a physician. Although it's an extra click for me right now, a click is much better than having to go back in the record, read it, try to understand what was going on at the time when a retrospective question comes to me.
Yeah, actually, I will add to what Tony said. We had a pilot of this tool in its very earliest form, and we did see evidence that clinicians actually learned and their documentation got a little more efficient as time went on. We're hoping to be able to duplicate those studies with a more robust tool now, but we would certainly hope that clinicians do learn. It's always been a question about clinical decision support. Does it teach or does it dumb people down? We think it teaches.
That's really interesting. Thanks for pointing that out. All right, so on to our next question. An audience member says, CDI technology shifts the burden of process improvement from the back to the front of the documentation lifecycle. How do I balance this with the traditional CDI program, where the clinical documentation specialist has responsibility for ensuring not just the completeness of the documentation, but that the appropriate patient acuity, severity, and risk of mortality is captured as well? Is there room for both?
I think I sort of answered that, but I will say definitively, yes, you need both. All that a tool like the two that I showed is going to do is going to decrease some of the routine and mundane burden on the CDI specialists. There will always be a place and a need to do more in-depth clinical documentation improvement at the back end, but everything that we can move to the front end makes that job easier, makes the task faster, and I realize that finance isn't our primary driver, but it will decrease the DNFB, or decrease it, I guess, the time on DNFB by making the whole process faster. But you need both, absolutely.
And I would add, the other part is that the engine, when we present the clarification, if we're presenting it directly to the physician, we want to be relatively certain that and clearly we want to be certain that that is an appropriate clarification because it hasn't touched a CDI specialist to actually look at it. So the depth of opportunities that are going to be front-end available to the physician may not be the same level of depth that a CDS is going to achieve by looking at the record. The second piece of that, though, is although we showed you the physician-facing parts of this technology, we also have CDS-facing parts of this technology, where the opportunity for a clarification, instead of going directly to the physician, actually comes to the CDS. And they can look at all of the evidence at the time it was presented so they can see where the engine found it, see if that was appropriate, and then see if there's additional information that's needed, and then potentially send that clarification out to the physician. So there is a second level here that we didn't talk about, and that is the CDS facing piece of this technology.
Thank you both. That was very helpful. So our next question from the audience, can you suggest ways to drive physician engagement and ultimately successful adoption of speech recognition technology?
Yeah, the first thing I would do is put the ProPublica website in front of them. And I've been trying to drive physician behavior based on their performance compared to others for the last 10 to 12 years that I've been dealing in this world. And it's always been more successful than if I talk about financial impact. Mostly because most of the financial impact of CDSs or CDI programs have been on the hospital, not necessarily of the physician. I will also tell you that as transparency becomes bigger and their performance is measured and put out there for people to see, physicians are very competitive people. And they don't like to be average or especially below average. So I think that physicians move on reputation much more quickly than they move on financial incentives at the end of the day, because it's linked to the type of clinician they are or are perceived to be. So I believe that the more we can show them how what happens with their documentation translates to how the rest of the world will begin to perceive them as a physician will have a huge impact on continuing to gain their acceptance and engagement in this world. Also, as you move towards ACOs and other risk-bearing types of payment systems, those are going to be directly impacting that physician's pocketbook. You put the two of those things together, reputation and pocketbook, and I think you have a real good recipe to get them engaged in wanting to do this correctly.
Thanks, Dr. Leib. That makes a lot of sense. So for our next question, can you use your results to identify appropriate use of resources, such as medications, lab, x-ray, etc., for each patient or by each physician? So can you use your results to identify appropriate use of resources for each patient or by each physician?
That's a great question about where we are going in the future as opposed to where we are today. Yes, very clearly, once we have gotten over the big hurdle, which we have, of being able to capture the note, analyze it, break out the concepts, then your question is, are there rules available for what's the appropriate use of those various modalities given a specific diagnosis and severity? Those rules exist. They can be made computational, and we can present the information, but we're not doing it now. You know, you take the biggest chunk first, and there is no question that the biggest chunk has been coding, billing, severity of illness, risk of mortality, quality metrics, but the other stuff obviously can work with this kind of program and will in the future.
Thanks, Dr. Coleman. So for our next question is another forward-looking question. Can you speak to what's next and the roadmap for the future in this space? Could this technology recommend ICD-10 codes to improve coding? Could it eventually completely remove the need for physicians to chart, allowing them to just sign off and approve?
I'll jump in first, and that's great. It's a great question because it really does sort of drive to where we see the future of physician-patient documentation interaction, right? So there's three pieces now that have become important at the time of a encounter. There's the physician, the patient, and the medical record. Medical record wasn't important for a long period of time until electronic medical records sort of came into play, but now they're very obtrusive and they're present in that interaction, which is disruptive to the patient and the physician interaction. We see a future where, if you think about it, the concept of actually having ambient technology where a physician walks into the room with a patient. Patient may have a family member there and could have a nurse with the physician, and they begin to interact with the patient, and the technology is able to distinguish which person is actually talking through biometrics, voice biometrics, is able to capture vital parts of that documentation and begin to enter it into a structured format, into a record, so that when the physician completes the visit, they could walk out and all of that information is presented to them in some structured format that they can review and potentially sign off. That is exactly where we think the ultimate forward-looking technology would drive us. What we're trying to do now is do that with people, right? We use scribes and other things to try to do that. We think that the future is going to be based on technology being able to do that and do that much more efficiently than humans can do in a scribe world.
And I'd like to add to Tony's answer because I agree with everything he said. My understanding of the question was a little different, though, about can it recommend ICD-10 coding so that the physician does not have to select codes. And the answer is yes, no, maybe, sometimes, and always never. The issue with selecting the appropriate ICD-10 code is adjudication of what I would consider conflicting codes. And one of the patients that I did a demo of is a classic example. The patient has diabetes and nephropathy. But at another point in a clinician's note, it will say that the patient has diabetes and neuropathy. Well, actually, those are two different codes, and deciding which one is appropriate or if there is a code that encompasses both is surprisingly complicated technology. So we're a ways away from being able to do computerized coding. We have tried to do it. We have sold a computerized coding product, and we found that the complexity of the issue makes it very difficult for people to implement easily, and we're not pushing on that until we get some better development.
Perfect, thank you. So it looks like we have time for one more question here. Our next question comes from a Fortune 100 risk management consultant, and it's about small rural hospitals. So let's see. We are using significant resources to keep current predictive modeling technology. We are finding, though, that a great majority of rural hospitals are not quite so current, even though MACRA is the ground rule for physician compensation. Please recommend staging of AI PM for small rural hospitals.
I'll answer that with a simple expression, and then I'll elaborate. The cloud. The tools that we demonstrated today are cloud-based. The small rural hospital doesn't need anything more than an internet connection between their EMR and our data center to get the kind of analysis and feedback that we're providing. So the small rural hospital has a great deal of difficulty implementing programs themselves but it is not hard for the small center to connect to this kind of tool that is cloud-based, does not require any advanced infrastructure on their part, and makes it much easier for them to get the same advantages that the big boys are getting.
Perfect. Thank you, Dr. Coleman. And it looks like we have time to squeeze in one more question. An audience member would like to know if this approach will also work with clarifying and mitigating surgical complications.
Tony, do you want to try that, or do you want me to?
Yeah, repeat the question for me real quick.
Sure thing. Will this approach also work with clarifying and mitigating surgical complications?
Yeah, so the biggest problem that we have with surgical complications, at least that I find, is that many times a surgical complication is really not a complication, it's just coded as one. And it's coded as one because the language that's appropriate to mitigate that to a comorbidity and not a complication is not there in the record. So one of the aspects that we that is a problem that CDI teams can begin to address is, did we get the appropriate documentation that allows for what happened to be appropriately captured as a comorbidity and therefore a CC or an MCC as opposed to a complication? A good example of that may be someone who comes in with a spinal tumor that is causing a neurological compromise, and they're on Plavix. You can't wait and delay the surgery, so you're going to have to take them to surgery immediately, even though they're on Plavix, which means that they're going to bleed post-op. Is the documentation there so that the bleeding post-op is not captured as a complication, but actually as a comorbidity challenge that the physician has? And yes, this type of technology can be used to evaluate circumstance. It can be used to evaluate not just circumstance, but current medications and the impact on a current circumstance. So yes, as we look forward, that's the type of things that this technology will be able to do.
Thank you, Dr. Oliva. And that's all the time we have for today. I want to thank Dr. Oliva and Dr. Coleman for their excellent presentation, and to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you, everyone.